space medicine and procedural space and operational space medicine is actually quite similar to rural medicine in that it's remote. Rural is resource limited, so you have to do what you can with what you have. We'll get questions about, well, isn't it just the same? The steps are the same, but the logistics are different. So the most important thing is thinking about how microgravity will affect your ability to perform.
Hello, everyone, and welcome to the Paratus Podcast, the Emergency Preparedness Podcast. I'm really excited to have Dr. Shawna Pandya today with us. She's an emergency and aeromedical transport physician and a research astronaut with the International Institute for Astronautical Sciences, where she also serves as executive director for the Flight Opportunities Program and teaches space medicine in extreme environments. She's a faculty at University of Alberta, and her work sits at the intersection of clinical care, human performance, and operations in high-risk settings, from remote and austere environments to human spaceflight. She also serves as a medical advisor to multiple organizations working at the edge of human performance and space health. Shawna, thank you so much for taking the time and being here with us today.
Thank you so much for having me. I'm really excited to have a discussion today. I think we're going to talk about a lot of technical, operational, and crisis management points that I think will have a lot of value to a lot of the listeners out there.
Absolutely. And it's so exciting that we talk today because we're recording on April 2026. And obviously yesterday was the flyby of the moon with the Artemis crew, which was absolutely amazing. And I want us to go into some space operations and medical operations things for sure. But first, I'd like if you could start us with a case to get the discussion going.
Yeah, for sure. So as many who follow my trajectory will know that I still actively practice rural emergency medicine. That is I call it a Batman Bruce Wayne scenario. So on every weekend, every holiday, every long weekend, I'm off in some rural and remote community in Alberta covering the emergency room. And then I don't know if it's the Batman or the Bruce Wayne part. The weekdays are all of the research, teaching, space medicine. And so every day is like a box of space medical chocolates. You never know what you're going to get. So we're going to start with a hair-raising case, very, very similar to things I've encountered in the wild. We've just changed a little bit of the details to protect patient privacy. And so I know that there's a lot of first responders, emergency medicine physicians out in the audience. And so I think we all appreciate how emotions go high and how terrifying pediatrics can be. So this one is a pediatric resuscitation case. And so, imagine you are the physician in a community, a remote and rural community. And when you're rural, you are it for being the physician. You are the one covering the emergency room. You're the one covering the entire hospital, long-term care, auxiliary, everything. And so if you're covering over Christmas or New Year's or Easter long weekend, it can be 100 plus hours on call. And so when 8 a.m., the Monday or Tuesday off call approaches, you start to get pretty excited. And so you are about to come off call. And then at 5 a.m., you are called about a patient coming in. And oftentimes what many of us will do if they're not urgent is, say, okay, let's hand it over to the next guy just for human factors so they can get the best care possible. But then the next line makes you sit bolt right up in bed and say, I'm coming in. And that line is, we have a pediatric patient not maintaining their airway, they're begging. You say, I'll be right there. And so basically what has happened in this case is there is a suspected status epilepticus, a prolonged seizure. Patient has not maintained their airway. So the first responders are begging for them and you come on scene. And so at this point, you're making a few decisions. Oftentimes, as we all know, you might have a prolonged post-ictal or post-seizure period. And you might just say, you know what? Maybe intubation is not the right thing here. We're just going to beg them and see if they come back. And as the scenario progresses, you realize this kid is not going to maintain their airway on their own. And as you work them up, you realize they've completely aspirated and one of their lung fields is completely obliterated. And so they're starting to lose their saturations and now your hand is forced. So you need to intubate this patient. You try to call for help, but sometimes you do get backup intubation, but for right now, you are the only physician. And so as you're thinking about all this, you try to think about how do I set myself up for success? And in my case, what I do is I call for backup often. So we have this great system in Alberta where you can consult a central provincial service. And if it's what you call an unstable patient, you will get your transport physician online and you will say what your case is, what you need help with. And so obviously, when you have a kid who needs to be intubated, you will definitely call for help. And the response you get back is, hey, we like what you're doing. Both of our pediatric critical care teams are out on other calls. So even though you're closest to Edmonton, we're going to have to call in a team from Calgary. And we'd love to help you out with medevac, but because of a blizzard, STARS, our air ambulance, is not flying. So it's going to be a fixed wing to the next closest community when the weather allows them, and then they'll drive over to you. So already you're thinking this is going to be a prolonged resuscitation. In the meantime, you're making your intubation plan. You're thinking about things that can go wrong. And in the background, you're kind of making a plan for emotional support and just kind of running the plan informally by other colleagues who know exactly what you're dealing with and just kind of saying, what am I missing? Because the patient is stable. You're dealing with problems as they arise. The patient's saturation continues to go down. You're increasing the oxygen flow. You make your attempt at intubation. You miss the first time. Make your second attempt. You get the tube in. As expected, as we can see with the pediatric patients, they go bradycardic very quickly because of the vagal response. You give some atropine. They brad down further to 20. You do maybe one quick chest compression before they come up. And so it was a vagal response. So first problem solved. They're intubated. Great. Now to wait for medevac to make their way to you. It's going to be a while. But now your patients, despite being intubated, is losing their saturations. What do? You start to troubleshoot. We all know the dope mnemonic. You want to make sure that your tube is in place. It's not too far. You haven't intubated the right mainstem bronchus, that it has not been dislodged, that all your equipment's working, that you're getting proper end tidal. You've troubleshot and they're still losing their saturations. And so now you're down to a place where you're uncomfortable, where it's maybe in the 60s, and you don't need to be an expert to know that having an oxygen saturation in the 60s is not a good place to be. And so this is kind of where you have to make sure that there's no ego involved, that there's no sense of, I don't need to call for help. You want to do what is in the best interest of the patient. So you are on the line with the critical care teams, the pediatric critical care teams. And, they're the experts in this. They see this all the time. So they're telling you to go up on the positive and expiratory endal pressure, the PEEP. And so you're going up to adult level volumes of PEEP. You might be going up to 15 on a child who's tiny. This may not be beyond your comfort level, but this is why you're talking with the experts. And suddenly you get the oxygen saturations back. So it's merely with the troubleshooting, it comes down to, trying what's new, asking the experts, and, problem solving as new issues arise. And so now you're back into a saturation where you want to be. You get the update, medical transport may be on their way. You're maybe several hours into this resuscitation. And now the next problem arises. Patient is starting to lose their pressure. And so this might be because of the high PEEP that you're using. And now you have to think, okay, how do I troubleshoot this? We are in a site that is rural. We don't have many resources. We don't have a central line if we need it. What can we do to manage this? And so by this time, the resuscitation has been going on for 8+ hours. Your rural resource and staffing and team has been rock stars. Your emergency medical services crew has stayed with you. Their arms are super tired from bagging this whole time. You don't have a ventilator. And then just as you've kind of are starting to decide what to do about the pressure, 8.5 hours into the scenario, the critical care team from Calgary has flown into the nearest community. They come, they bring a central line, and they start helping with the pressure. And so this is, although the patient details have been changed to protect privacy, this is a very real scenario. And I think it's a really good one to talk about the resource limitations, decision-making, the stress, the fear, and at the end of the day, working together to do what's in the best interest of the patient.
Yeah, that's amazing. I'm tachycardic right now, so I can't imagine.
Yeah, reliving it.
Obviously, it's so different when you're working in a tertiary center where you hear the same call and you know that help will be there probably within 3 minutes, even before the patient's going to be there. How does that change your mindset? So when because you're working in different communities, how does that change your mindset from how far the communities are, what's available?
Have to, because I worked at 35 to 40 sites across Alberta now. And there's been sites, Murphy's Law of emergency medicine says that the day that you're like, you know what, it's probably okay that I look at the airway stuff in the morning. It's been a long, long night. I was at a site I hadn't been to in years, and I was there for maybe 90, 87 hours. And I thought, okay, it's fine. And then, of course, at 3 a.m., I get called for a crash, respiratory distress. And it's like, we need to know where the airway stuff is. And so you don't want to be caught in that situation more than once. If it is, that's on you. And so, you have to be thinking ahead. In emergency medicine, you're always thinking about what's most likely, what else could this be, and what do I not want to miss? And, especially when the emergent cases, the resuscitations, you want to be as prepared as possible. And I think anyone who's ever had to intubate wants to think about, what am I going to do if I cannot get this airway? It's you don't get to choose which patients are going to need to be intubated. And more often than not, it's going to be the BMI 40 guy with sleep apnea, big beard, and no neck. And you want to be as prepared as possible. And even if that, is quote unquote failing and you miss the intubation and you are using your eye gel, but you have proper air entry, oxygen saturation, low resistance to bagging, that's what you're going to do. And then, of course, there's always that sphincter tightening moment of, what if I have to crate this guy? So that hasn't happened yet, but it's, now I'm getting tachycardic thinking about that. So it's your job in any high risk operational setting, especially where lives are on the line, is to think about, what is the worst case scenario and what am I going to do if that happens?
So take us to when you go to a place you haven't been in a couple of years. What's your routine usually? Do you go around the place? Do you, talk to people? Do you look where their equipment is? Zach, how do you enact that?
Yeah, I think knowing where the trauma bay is, what their resources are. And in most cases, it's very similar. It's kind of lucky because I think that most hospitals in Northern Alberta were designed by the same architect. They have a very similar layout. And sometimes you have to ask yourself, which community am I in? And so it's like going to the trauma room. Where is the crash cart? Has it, they by protocol, they will have been updated. What do I have here? Going through the mental scenario of like, if I have to tube an adult, what size endotracheal tube am I going to use? What size, am I going to use what kind of blade am I going to use? What size am I going to use? What are my backups? Do I have a video laryngoscopy? Am I going to use a bougie? And it's sort of like the other challenge of this is knowing that, like, hey, intubations don't come up often. So it might be that you have to say that, like, my job is to lead the recess, and if another physician is available, I'm going to call them to manage the airway so I can maintain the bird's eye view. Often, most times you don't have that. So you might say, EMS, you are going to be my airway manager because you do this a lot more often so I can maintain the bird's eye view. And, you just have to say that I'm not going to be the one intubating in this case. Or sometimes you'll say, I'm going to take the first attempt. If I don't make it, we're going to give me one attempt. So I'm going to step back so I can keep the bird's eye and you take over. So you have to, there's no ego in that, right? You have to say, like, look, if I get so fixated, if I get this fixation bias and it's like, I become so enamored with my skill level and, my ego is going to be crushed if I don't get this airway. And then you keep on trying and your patient's desatting to 60. You're not helping anyone. They're probably not going to ask you back to that community again. And, at the end of the day, like, what's more important, that this patient had a successful airway attempt or that you said you got the airway on the 4th attempt? And then also having the discipline to stick to what you're saying. If you say, I'm going to make one attempt and then hand it over, you're going to stick to that. If I'm going to take 3 attempts and then if I don't get it, we're going to go back to begging while we regroup or have the IGEL ready, you have to have the discipline to stick to that.
Yeah, that's so interesting. And it makes me think, because we'll talk after, obviously, with the astronaut preparation, where in small groups, you probably get like tens or hundreds of hours working with the same person. Now, what you're describing, you show up somewhere and you probably never have met these people. How do you find you're able to prepare for these situations so they don't happen often? You're with people that you don't work with very often. Have you found there's a way to, ahead of time, when you arrive, get people ready and on the same page? Is that something that happens more right before the event where you're kind of reciting your plan? How do you find that works best?
I love that question because it's so important. It comes up so often, but I've never been asked that. And so, it's a mix. It's a mix of a lot of things because in some of these sites you go back to often enough, you're on a first name basis with each other.
Yep.
Luckily, rural is filled with tertiary care ICU and emergency nurses who are looking for a change of
Mm,
pace. So for them, this is, their bread and butter. And then there's also how you communicate in high stress operations scenarios. And so there's this chain of command that goes question, suggestion, statement, command. And so how you speak and how you communicate needs to be tailored to the urgency of the scenario. And so, question, suggestion, statement, command in a non urgent scenario may be like, hey, do you think this guy needs fluids? And then the suggestion may be, why don't we think about fluids for the pressure? And then the statement might be his pressure's low. We need to address that. And then the command is his pressure is 60 over 40. He need fluid resuscitate him now. And you need to come in with that understanding because if you in a non-urgent scenario are constantly giving people commands, you're not
mm,
respecting their autonomy and their experience as healthcare providers, regardless of what level of training they're at. But if you come into a recess scenario and say, hey, the trauma team leaders, do you think we should do chest compressions? You're going to lose a lot of faith from the team off the bat. And so when I am in a recess scenario, I don't care if I know everyone's names because there's also going to be new faces that I don't know. What is great about rural is the EMS, the emergency medical responders, they know that they will be your hands. They will be so proactive about getting the IVs, getting the monitors on, sticking around. And so you'll just ask for everyone's names and then you're going to be very, very direct. It'll be like, Jean-Francois, you need to start the IV. It'll be so-and-so, you're going to beg. And so you're going to be very, very direct so there's no confusion. You're going to ask for closed loop communication. So if you're, giving epi, you're going to say, I want you to give in 1 milligram of epi and then tell me when it's in. So there's no chance for saying, oh, I think I heard a request for epi. I'm just going to assume that maybe if it's important enough, they'll say it again. And then the other thing that I've started to notice in more resuscitations is emotions run really, really high. And sometimes we can
mhm.
say things that we don't mean. We can be maybe less respectful than we um, intend to because of stress. We might not agree with the decisions that are being made. We might roll our eyes. We might say, why would you make that suggestion? You don't need to respond to it because that's not what the scenario needs. So, one example recently, we were in a recess situation and it was a patient on the floor who'd crashed. And what I've learned is you can try to resuscitate a patient on the floor on the long-term care. At the end of the day, you need to be in the trauma bay. That's where your resources are. And that's where the mental shift of this is serious comes. So from like now, the second I think a patient needs a recess, we bring them into the trauma bay. And so we ran into this scenario where the hospital doors were not working as expected. And like we we were held up a little bit trying to urgently wheel this patient in need of a recess to the trauma bay. And we struggled with that, not for too long, for a few seconds, but in the moment I said, we need to submit an RLS for that. So that's our way of saying this was suboptimal. It can affect patient care. There's no consequences, as in no one gets trouble, but it's something that will be addressed. And someone who was new to the system was saying, are you serious? Why would you submit something about that? And I didn't respond to it because I could see that they were stressed by the scenario. But it's sort of like in your mind, you're thinking so many different levels. You're thinking in the moment, you're thinking a few steps ahead, you're thinking about what this patient ultimately needs, but you're also thinking of the next time I'm in this scenario, I never want to be held up by a faulty hospital door again. And so you might, I understand this person's stressed. I'm not going to take, the are you serious personally? I'm going to, maybe explain and debrief later that if this were a code and their heart were stopped, those seconds could impact the patient outcome. That's why I'm serious about something as simple as a faulty hospital door. So, the human factors are so important to understand. Tensions are running high, even if you know what to do. Like coming back to this pediatric case, you know what you're doing. You know what your backup plan is. You have help on the line, but you still don't, at the end of the day, I always make a point to debrief. And at the end of the day, when we debriefed over that, I think my literal words were, we had the best possible outcome. Patient did well, but that did not feel good, right? Because
Yeah.
Child's life is on the line, and you can acknowledge that. And so these high stress situations don't feel good. And just acknowledging that we may not be at our best selves because of that stress is so important to acknowledge and not take personally.
Yeah, that's awesome. And it's the first time I hear that explained that way. And it just makes so much sense that different situations call for different ways to communicate. I want to do a little segue into space and obviously going to what happened in the next few days, but just getting into it, what have you found in terms of the way that people train for obviously aerospace medicine, but also like space in general, like the astronauts that will get ready for missions? How is that different from the way that we train in medicine and especially emergency medicine?
Yeah, it's actually a lot more similar than we might think. So, the differences are, first of all, the lack of gravity and the resources and the time to medevac. But actually, if you're doing an emergent medevac on the International Space Station, like if you had a fire and needed to get out now, there's always a crew return vehicle. There's always a return vehicle docked to the International Space Station. So if the plan was to evac immediately and then re-enter on a ballistic trajectory, it would be high Gs, it would be uncomfortable, and you might be in an off-nominal landing site, but you would be back on Earth in as little as 3 to 6 hours. And so if you compare that to the 8-hour resuscitation, you actually have comparable, if not better, return to medical care times than on Earth. But, you need to think about, the biggest thing is how you think about procedures in microgravity. And so sometimes, when I publish or show some of the protocols we've practiced, something as non-urgent as IUD insertion in microgravity, we'll get questions about, well, isn't it just the same? The steps are the same, but the logistics are different. So the most important thing is thinking about how microgravity will affect your ability to perform, as well as fluid management and instrument management. So step one is to always stabilize the patient. On the International Space Station, they have the crew medical restraint system. On the Integrity Orion capsule with Artemis, they've done some demonstrations about how they might do CPR. So it doesn't seem that they have a crew medical restraint system from some of the demos they've given, but they talk about stabilizing themselves and wedging themselves between the wall and the ceiling to get that stability. So they're not, Newton's third law is not careening them across the spacecraft. So you're stabilizing yourself, you're stabilizing the patient. And then what is your plan for fluid management? So I once had a chance to talk to Jay Bucky about performing spinal surgery on neonatal mice on space shuttle on Neurolab. And I was saying, what are you doing about the blood? And luckily the cohesive properties of blood are just such that they stick together, so you can take gauze and just wick it away. And then the instruments, you're velcroing them down. So if you don't think about that ahead of time, it's going to be a mess and you're going to have a rough time. And there's some really cool studies from attempts at intubation with direct and video laryngoscopy in air flight that show that if you're not stabilizing the patient, even if you're an experienced provider, your attempts at success go way down. So that's a really important consideration. All other things, coming back to the big picture, I like to say same but different, in that space medicine and procedural space and operational space medicine is actually quite similar to rural medicine in that it's remote. Rural is resource limited, so you have to do what you can with what you have. You have to call for help early and often. And, if you are in a space mission profile that allows for real-time communication like the International Space Station, make use of that resource. And so, you and I both know this. We both have developed technologies for the Canadian Space Agency that can positively impact rural healthcare on Canada, but will also help astronauts in space. And the idea is, let's do the best we can for patient care in space, in rural, because they're both resource limited environments.
Yeah, that's amazing. How do you do you prepare the same way? So like you go into a rural emergency department or you go into a spacecraft. Would you see that as the same type of like preparation for the medical person? And obviously aside from microgravity, is
Yeah.
there like a way that you would prepare differently, or like is the mindset similar in terms of everything we've been talking about since the beginning?
Yeah, that's a great question. So I have not flown to space yet. I will fly as early as the end of this year, early next year. And so that'll be a suborbital mission profile. So the nice thing about a short same day mission like that is usually by the time you identify a medical issue, it's either you're waiting it out or you're already on your way back to Earth. When you're looking at a longer mission duration like the International Space Station, the training becomes really different because you're not always guaranteed to have a physician on your flight, but you will have a crew medical officer. And once upon a time, the crew medical officer, they may have zero medical training. They might be a physician. They may have EMT level skills. Their curriculum used to be 40 to 60 hours of training, but now with the astronaut curriculum being as inflated as it is, it's now about 10 to 15 hours. And then however proactive they choose to be, going to the hospital, learning to start IVs, learning to intubate, learning to do catheters in case of urinary obstruction. So you're actually really relying on your remote support with 24 flight surgeon coverage. And then when you get to the moon, you have a 2-second time delay, but you can still have a real-time conversation. So you can still rely on that crew medical care. Now, there is that scary period of blackout communications. So we saw that with the Artemis crew yesterday when they had a 40-minute communication blackout, or LOS, loss of signal. So, it's terrifying because not only are you alone, hopefully nothing medical happens during that period, because then you really are on your own. So that's when you kind of want to think through what could happen, what's most likely to happen. The odds that someone would have a cardiac arrest in that 40-minute period, super unlikely, but the crew was trained on CPR. But now let's take the case of, what about a Mars profile mission? That becomes terrifying because depending on the conjunction of Earth and Mars, you have a 6 to 9 month journey to get there, 6 to 9 month journey to get back, assuming you have a favorable launch window. The communication delay might be 6 to 48 minutes round trip. And then there's also that period when the sun sits between the two planets when you do have that same LOS, but this time it's not 40 minutes, it's 2 to 3 weeks. So now that's the ultimate in not rural, but remote and resource limited care. And so there's this concept of operations that exists for Mars level medical care, and it's called Earth independent medical operations. And so there's some really cool papers out there on that. NASA has put out a paper on the Mars medical concept of operations, and there's this really scary table in there that talks about medevac capabilities. And when you're on the launch pad, yes, you can medevac if something goes wrong. If you're on Earth, yes, you can medevac. The second you make that TMI, that trans-Mars injection on the red planet and orbiting Mars, you are out of luck. And if you're on your way back to Earth, but you just took off from Mars, no Mars medevac capability. So now the question is, are you just not sending your favorite astronauts, or are you planning for, how are you planning for that? So how do you increase your crew's independence? How do you increase their autonomy, their skill set, and then what enabling technologies can you have? How do you maintain their skills level, their muscle memory? How do you increase that just-in-time training? And then this is where cool technologies, that you and I have worked on become really relevant, because at the end of the day, everyone's happy when the astronaut crew is healthy and thriving.
That's so interesting. And it sounds just so much like your rural story, just a little bit further away, basically. How can you 15 hours, you can't prepare for that many scenarios. From your emergency medicine standpoint, how do you train enough for that? Like, is it more of a let's wish nothing happens, or is there a way to train specifically?
Yeah, so I think you really still want to get into what is most likely to happen. What else could this be that you can't miss? And then what is the life or death scenario? And when you're looking at deep space missions beyond low Earth orbit, we call those exploration class missions. And NASA's done a really good job of looking at the medical risks. And that is based on what has happened in spaceflight, what's most likely to happen, and then also what will affect the success of the mission, as well as the astronauts' survivability. So there is something called the Exploration Medical Capability Top 100. So that's a former department in NASA's Johnson Space Center, the human spaceflight program, where they look at the top 100, and that's the everything from the super most common things like space adaptation sickness, where in the 24 to 72 hours, just by virtue of that transition to microgravity, you can become intractably ill. Have a plan for that. And some of it just may be risk mitigation. You're not going to do anything critical like a spacewalk within the first week on station. And then the more scary things, cardiac arrest, mass hemorrhage, that is all on there. And so there is a defibrillator on the International Space Station. They've never had to use it, but it's better to have that if life is involved, even knowing that everything you bring with you comes at a mass volume power cost. And, part of that reason is in previous space flights, we have seen transient runs of ventricular tachycardia, ventricular fibrillation, which again, anyone who knows what those words mean know that those are scary cardiac arrhythmias. What we know is they're self-limiting and that they are asymptomatic. And so we don't need to worry about them. But also, you don't just hope in a high-risk environment like spaceflight. You come prepared.
Absolutely. What's your thoughts on checklists and protocols? And I'd be curious because obviously astronauts use those a lot and they seem to use them all the time. Yesterday, I heard Capcom saying, this piece of equipment is in this locker, and I'm sure the astronauts knew where it was, but they're, still going through the steps one by one. So, what's your vision of checklists? And I'd be curious to hear if you use them in emergency medicine too.
Yeah, drills and sims and checklists, they're all so critical. We've learned some key lessons from the aviation and spaceflight world about being prepared. It is standard practice now. It is under the World Health Organization guidelines to have checklists for the OR. I've seen more and more of my colleagues think about the having intubation checklists. I know that the medevac does. For me, I take time to write out for my specific patient what is my plan, what is going to be my sedation, what's going to be my paralytic, what is my everything down, not just to what is my intubation plan, but like what size, what depth am I intubating to? And then, what's my backup plan? And then what's my backup plan to the backup plan? Who are my resources? Who are my personnel? And so in a high stress situation, the lesson is take the patient's pulse, but then take your own pulse. You have time to think. Like if it's a crash intubation, you have to come in not just knowing your emergency frameworks, the ABCs, but you have to be prepared to act. But even in a scary scenario like a resuscitation, like an air crash airway, you have that time to think about your next steps and also look at the surface level, but also come back to the bird's eye view.
Absolutely. Last question before we go to Artemis and have your thoughts. When you find like in terms of adult learners, so obviously you're doing a space mission soon. When you're learning what you have to learn, and there's a lot of material, how do you learn differently now that you probably learned back when you were in university? And is there a way to adapt learning?
That's a great question. I love that so much. And so I think, that comes into play in every aspect of medicine when I'm teaching space medicine, when I'm learning myself. And so what I love about being out in practice is that I find retention a lot easier because it's not, I feel like in med school, or even in undergrad, when you might be memorizing the mechanism of the lac operon in E. coli, something that we've all forgotten. If you were to ask me to draw out the Krebs cycle, I could not because, for me, I didn't see the practical application other than knowing it for the exam. Here, everything I learn there's a reason for it, whether it's the mechanism of a drug, whether it's what drug I'm prescribing, whether, it's explaining a pathology to a patient. So knowing the application and then also meeting your learner where they're at. If it's a patient, I often say that we're speaking English, but we're not speaking the same language. And so, if I'm trying to explain in great mechanistic detail how a 5-H2 antagonist works, that's jargon. But if I say that we're trying to slow down the acid production in your stomach so you have less heartburn, that makes sense to them. So, figuring out where your receiving audience is at, whether it's a student, whether it's a patient, that's really, really important. And then, practicing in lifelong learning, like being in extreme environment medicine, being in rural medicine, being in space medicine, like this is so exciting to me. I love learning about all of this. So, there's that hunger and it can seem really daunting when you're at the start of your career and you're told you have to be a lifelong learner. You're going to have homework every night for your life, for the rest of your life. I remember that seeming really daunting in medical school. And now it's like, yeah, I want to learn. Oh, and I get credit for this. I get CMEs for this. That's awesome. Because it's like, you're going to keep learning. You have to keep learning. The rate at which medical knowledge and guidelines are changing is incredible. And so if you want to keep up with your practice, do what's right by your patients and also be at the top of your field, you have to learn and just, figuring out how you best digest information is really, really important. And then in the era of technology, of artificial intelligence, of YouTube videos, there's so many more ways to absorb and learn. And so, for me, I find being able to explain it to someone, being able to explain at multiple levels is super indicative to me that I truly understand something.
Tell me, I want your thoughts. Once again, Artemis flew by the moon yesterday. So many emotions. I'd love to hear how you felt. I know you watched it too. What were your highlights? Just having your hot feedback from that happened less than 24 hours ago.
Yes, oh my gosh, I think the smile says it all. I haven't stopped smiling, all week. I was just texting one of my, extreme environment, medicine colleagues, and we were just talking about this, and you know, I think a lot of us who love spaceflight, who love exploration, we expected to feel the majesty and the inspiration and the wonder, but I think a lot of us were caught off guard by the sheer humanity of the moment. Watching the dedication of two new geologic formations, Integrity and Carol, being named Integrity after the Orion spacecraft capsule, in homage to the respect, the candor, the hard work that went into making this mission possible. And then more poignantly to Carol, who is Commander Reed Wiseman's late wife, but just seeing that name announced by Canadian Space Agency astronaut Jeremy Hansen, hearing the emotion in his voice and really understanding that it's not just for astronauts in space in orbit around the moon. It is all of the crew, all of the colleagues that put them there, the friends, and most importantly, the families that were there as their rock solid supports. And, seeing my own response, seeing the emotionality, wishing I hadn't chosen waterproof mascara yesterday, seeing my colleagues feeling the same, seeing folks who had no interest in space exploration, realizing that the point of exploration is that not that we're going to an environment that's barren, it's that we're bringing the best of what it means to be human with us to these environments. And to be in an age where we can see that in real time, to see all these moments, to live that with the astronauts, to see their wonder, their joy, their sorrow, their experience. It's been an incredible week, and I'm so delighted to be alive in this era and to be witnessing Artemis too.
Yeah, that's so exciting. Is there anything that you probably, you know much than the average person? Is there anything from the background, an interesting story, something about, the mission that's going on right now that you could share with us?
Gosh, there's so much where to start. There is a whole bunch of us in space medicine. There's a whole bunch of us in Canadian space and human space flight that are just so enthralled by that. So, just giving a shout out to the Canadians involved with this. Jeremy Hansen is the tip of the spear, but, Jenny Givens, the CSA astronaut who has been one of the Capcoms, and just hearing her voice and watching how rock solid she's been throughout all of this. She's taken on so much duty. She's been training as his backup. She's been testing experimental procedures, but she's also been a Capcom. We're seeing Canadian presences. So the 3rd Canadian Space Division also has a role to play in NASA. So Erin Edwards is the deputy branch chief of JSC, and she's also a Capcom. We're seeing Mike Green, the CSA flight surgeon. Like, there's a ton of Canadian influence. And, to see Canada put its best foot forward and to show the world there's a reason that Canada's the second nation to the moon, speaks to the experience, the dedication, the excellence. And it's just such a joy to witness. And I feel like Canadians everywhere should be really, really proud, but humanity should be really, really proud that we chose these 4 as our ambassadors.
What makes you optimistic, around the next couple of years in terms of space travel, in terms of your career, in terms of what's happening soon?
I'm so excited by this. Part of the excitement is I think this is the best possible time to be alive for human spaceflight. When I was a kid, the question was, do you want to be an astronaut? It wasn't, that was like, I want to be an astronaut, right? And now in this day and age, it's not just, do you want to be an astronaut, but it's what kind of astronaut do you want to be? And the definition has changed so much. Space agency astronaut, do you want to be a commercial astronaut? What kind of commercial astronaut? Do you want to go for, leisure and tourism? Do you want to go for research, which is what we do? Do you want to be an agency astronaut and then go over to the commercial sphere, which we're seeing with companies like Axiom and Vast and Max Space? Do you want to be an agency astronaut who flies commercially? Do you want to be a commercial astronaut who goes to an agency-controlled destination like the International Space Station? Do you want to go to a commercial station? Like, this is the world we're living in. The sky isn't the limit anymore. And, this is just in 2026. So I know that this whole week has inspired a future generation of engineers, pilots, physicians, explorers, and astronauts. And the question is, what do you want your mark to be in space, and how are you going to start architecting it? And so when I say this is the best possible time to be alive in human spaceflight, I truly mean it. And it's sort of, for me, I get to make my mark through the commercial sphere, through research, through space medicine, and to wake up and realize that the dreams I had for myself as a kid surpass what I thought my life would be as an adult is just so, so stellar.
That's awesome. Shawna, thank you so much for your time. I so appreciate it. The timing is amazing. I'm really looking forward to watching what you're going to do in the next years. And once again, thank you so much for your insights and linking space and emergency medicine. That's amazing.
Thank you so much for having me. This was such a wonderful discussion.